Hi, I'm Phil. I'm one of the anaesthetic registrars in NHS Lanarkshire, and this is our video on how to do nasendoscopy. So we'll talk you through the scope itself, and then you'll see myself being scoped by Mr. Chin. And
I'm Christine. I'm one of the anaesthetic ST7s that we're going to go through it with you.
And I'm Andy Chin. I'm one of the consultant ENT surgeons in NHS Lanarkshire who will be doing the procedure today.
This nasendoscopy video is a resource that we'd like any anaesthetist to use as a resource to learn the skill.
the video will be in three parts basically. So the first part is about the setup of the scope and the equipment itself, and then there'll be two videos on the scope being performed, both how it looks and what the actual user of the scope sees as it passes through the airway. So the first is that learning this skill does not mean that ENT should not be involved. So still, as you would normally do in any situation, if there's a problem with upper airway obstruction, involve ENT in the normal way. Also, learning this skill and using it does not guarantee easy laryngoscopy. So if there's a good view on nasendoscopy, laryngoscopy still might be challenging. For example, the patient with ankylosing spondylitis. And lastly, we'd just like to mention that as anaesthetists using this skill, we are not attempting to diagnose pathology. What our goal is to use this as an adjunct for airway management and to help with the decision-making process, as I said, not that diagnosis of pathology.
First of all, it's important for you to know where the scopes are located. Most of the scopes nowadays will be clean and they need to be tracked, so they've got one-way open stickers here with tracking numbers that you need to keep in the case notes. It's good as well to put a patient identifiable sticker onto the back so that we can keep track of who's the scope been used on. The next thing we need to do is we need to have a light source, and we've got two options. Either we've got a battery pack or we've got a cable. And for the cables, it's important for you to make sure that we've got the right attachments for the cable to fit to the scope. We also need to have some decongestants and a local anesthetic, and here we use lidocaine and phenylephrine. We need some lubricant, a water-based lubricant, and some alcohol swabs to keep the tip of the scope from misting, and just some general swabs and sometimes some tissue paper for the patient. Okay, the next step is now we're going to put the scope together. So we're just going to take it out of the sterile bag. Essentially, these are the parts of the scope. That's the viewing piece. You've got a little bit here to focus the scope. Most of the time it's already in focus. And you've got a little pivot here to move the scope end up and down. And this is the light attachment, all right? So there are two ways to attach the light with a cable. It's pretty straightforward. Just put it on and screw it on. And with the battery pack, there's a little notch over here, and if you put it on, you feel it suddenly go in, and after that, just lock it in place. And that's the battery light over there. Okay. So I've attached the nozzle onto the bottle, and I'm just going to prime it by pressing once or twice, and after which I'm just going to apply it to the nose. It's about 2 or 3 puffs each side, okay? Just inserting the nozzle in, 1, 2, 3, and on the other side, 1, 2, 3. Okay. It's quite important to tell the patient that a bit of the anesthetic will drip down the nasopharynx into the throat, and it'll numb the throat as well. It's a bit uncomfortable, but it will wear off in about an hour. It's important not to have anything hot to drink until the sensation fully comes back. There are two ways to hold the scope. One of the ways would be to use your thumb on the pivot to alter the direction of the tip of the scope. So what I would do is I would put my eye on the eyepiece and use my thumb over here to direct the scope. There is a second way to hold it, and on this instance you're going to use your index finger on the pivot, and again with the eye on the eyepiece, that will help you to direct the end of the scope up and down. You can also use your shoulders to rotate the scope in order to get a good direction. It's entirely up to your preference. Right, Phil, we're going to do a nasendoscopy today, all right? What I would normally tell the patient is I would normally say, I'm going to pass the scope into your nose, and it's going to run into your nose, down the back into your throat. The whole process should take about 2-3 minutes at the most. Sometimes we have to do it on both sides. I've sprayed up your nose, so it will be quite numb, but you will still feel some pressure, maybe some mild discomfort, but do your best to stay still. And what I'd like you to do is breathe through your nose and just follow my instructions, okay? Alright? So at this point, we're going to put some lubricant onto your swab. I'm just going to put the lubricant just on the scope, but avoiding the tip, because if not, it will affect your view. And after that, we've got to do something to prevent fogging of the tip. Now, you can use either an alcohol swab to rub on the tip of the scope, but I tend to just ask the patient to put a dab of saliva onto the tip of the scope. Can you stick out your tongue, Phil? Okay, just put a dab of saliva. Okay, tongue back in, all right? And we're ready to go. Okay. So the first thing you need to do is make sure that you're orientated well. Okay. And I like to just keep the scope nice and straight at this instant. There you go. And as you can see on the screen, and that would be the view that I would normally get if I was looking to the eyepiece. I'm going to use your left nostril first, okay? I'm just going to touch your nostril now, and I'm just going to start passing it into the nose. And over here, you can see the septum on the left. That's the inferior turbinate there on the right, and the middle turbinate there in the distance. There's just a very slight bend in the septum over there, but it's not restricting our path. The path I would normally take would be along the floor of the nose over here, bounded by both the septum on the left and inferior turbinate just on the upper right. I'm just going to start to pass the scope now along the floor of the nose. All the time keeping the tunnel or the view right in the middle of the scope. Okay, and we've approached the nasopharynx. And sometimes the nasopharynx is closed, and I'll ask the patient just to breathe through their nose to open up the nasopharynx, and at this point I'm going to direct the scope downwards and continue advancing the scope, and you can start about to see the tongue base there, and just over here that's the uvula, and in the distance the epiglottis. And I'm just going to carry on advancing the scope now, keeping the view right in the middle, and you can see the vocal cords in the distance there, right? So we've got a very normal view in this situation. I'm going to look as well on the left and onto the right. I'm going to ask Phil just to stick out his tongue, and that opens up the vallecula. And put your tongue back in. I'm just going to ask you to say E. E. Yeah, that's good. Looking very normal. Checking for cord mobility. And I'm just going to approach a bit closer now, trying my best not to touch any structures, as that could cause a cough or a gag. And say E again. E. Good. And if possible, if you sprayed it up very nicely, you can also sometimes just pass the scope past the level of the vocal cords. Okay? Right. And as I come out, I'm just going to straighten the scope as we come out of the nose very gently. Well done. Okay, we're going to pass now to Phil's right nostril. Alright, just start recording this. Again, just check that the orientation is correct. Again, it's just a natural viewing angle. I'm just going to insert the tip of the nose, tip of the scope into the nose. And over here you can see the septum on the right, inferior turbinate over there. This is the middle turbinate. Get a little bit more narrow on this side, but we're just going to approach it again using the floor of the nose and this little tunnel here that's bounded by the inferior turbinate, septum, and the floor of the nose. Again, keeping the view always in the middle of the tunnel, and approaching again the nasopharynx. You can sometimes get enlarged adenoids just over here, and ask the patient to sniff in just to open up the nasopharynx. And approaching it further down. There you go.
Cool.
Yeah, so in an outpatient setting, you won't have the camera stack, and this is basically all you have. It's relatively straightforward and almost exactly the same. First thing I would do is just again orientate your scope, just looking just at the tip with the patient in view. And as you insert the tip of the scope, I wouldn't be looking at the eyepiece. I would be looking at the patient just to get the tip in, and at that point, move on to the eyepiece and just carry on as usual. Okay. Okay, so after you've used the scope, we've got to put it back into its bag, and it's important to check what the local policies are. So what I would normally do is just wipe off any excess lubricant on it. Insert it back into the bag and seal it. Most units now have a identification sticker over here, which goes into the case notes, as well as a tracking book. Often a patient identification sticker with a KI number would either be put onto the bag or onto a tracking book. Okay, but this goes into the case notes.
In addition to this video, we have also developed a nasendoscopy leaflet for anaesthetists that goes through contraindications, the description of actually carrying out the nasendoscopy, and there's some diagrams as well, just as another resource to help you learn the skill.